Merry Christmas, everybody. I want to make a video here today, a little bit more provider education for you on these new E&M, Evaluation and Management 2021 rules. I have listened to a lot of webinars, a lot of teleconferences from CMS and WPS, which is our Medicare carrier. These question and answers, this document that we're going to read through today together, is a snippet of a main question and answer document. The main document was 29 pages long. What I did is I went through and copied and pasted and made this document for us to review together today. These questions I feel were more provider driven and I think would help with your level of understanding, and so that's why we're doing this today. You can obviously click on the link and listen to me. You are able to read the document on your own. You can do both. It doesn't matter either way. So starting at the top here, the Ask the Contractor Evaluation and Management Office or Other Outpatient Services, that does go into effect here January 1st of 2021 and then after. So these were the webinars. That's the name of them, the Ask the Contractor. You could poll the audience, go in and ask WPS, how will you do this? How will you address that? How should we address this? How should we address that? These questions and answers, it says, apply to E&M Office or Other Outpatient Services code provided January 1st, 2021 and then after. Okay? Question number 1. If we document time, would any auditing just look at time? For example, if time met the 99213, but the MDM met 99214, which would WPS allow? Now remember, you need to take a split second after each patient starting January 1st, and you need to say, did this patient just take more of my time? I had more time spent with that patient, not a lot of work. Or did this patient take a lot of my expertise, my education? I did a lot of work with that patient, ordering tests, things like that. Okay? One or the other is what we have to choose from. You have to decide, and it has to be on you. You're the only one there that was with the patient and knows what happened, right? You have to tell the patient's story about that visit during your note. So they're saying, if time met this, but MDM met this, what do we do? Okay, and what are you going to do, WPS? It says, the answer they gave says, choose your procedure code based on that medical record, that note in Epic. WPS will review the medical record under both time and the MDM guidelines. We will choose a code that's most advantageous to the provider. That sentence is a big deal. I don't think we've ever heard anything that's going to be most advantageous to you as the provider. So this is going to be good. The next question, if we decide we will document MDM, must we also document time? This question I'm on the fence with, and here's their answer. They say the best practice is to include both. You can then use either time or MDM to choose the level of service. It says choose based on which is more advantageous, again, to you as a provider. Should Medicare contractors review your note, we will evaluate based on both if they're both noted in the medical record. I feel like this is going to cause more confusion. I feel like you need to make that conscious decision after every time you see a patient. Is it this or is it that? Okay? You're the only one that's there. You're the one that knows best. Okay? If you put in both, what they're saying is you need to document there was a moderate level of medical decision making and also 15 minutes was spent with the patient. They want you to state both, okay, which I think can be more confusing. If you want to talk more about that, we definitely can at a later time. Okay, let's move on. This video is only 15 minutes long. It cuts me off at 15 minutes, so I know that it's going to be less than 15 minutes, so I got to keep moving. Our doctors do the review of charts the day before the visit, so they're prepping before. Can we count this time towards the total time of the patient encounter? This is a very nice black and white area of the new rules. It's absolutely not. No. Use only the time spent on the calendar date of the patient encounter. So we can only use any time spent with that patient regarding that visit on today's date of service. If you finish up tomorrow, too bad, we can't use that time. If you start the day before, too bad, we can't use that time. If you prep today, and a lot of providers are saying, 5 minutes for prep time, okay, before you see the patient, and then you see the patient for 15 minutes, and then you know you're going to have a phone call later today from a provider, or maybe the patient needs to call you back with some information from home. You can count that time too if you know that's happening today. Okay, you don't have to wait till the end of the day to do all your charge capturing of your patients so that you can total up and tally time. Okay. Previously, Medicare required more than 50% of the face-to-face time spent in counseling and or coordination of care. We had a lot of these blurbs we were using. If you were going to bill on time, the rule was it had to be at least 50% or more spent in counseling and or coordination of care. Is that rule still correct? Another black and white? No. Choosing your level of service based on time doesn't require any counseling or coordination of care. Okay? Our documentation using MDM shows a level of 99205 or 99215. 05 is the new patient code, 15 is the established patient code. Our time, though, supports a 99202 or 212. What will Medicare do is what they say. So if the MDM was a lot, and they're saying it's really high, but the time is really low, well, what do we do with that? When Medicare evaluates documentation, and they kind of talked about this before, we will evaluate based on both. We would accept your level of service when your documentation supports a 99205 or 215. We would not compare the time against the MDM. Again, what's more advantageous to you as the provider is what they say they're going to do. Patient encounter is for a yearly physical exam and treatment of an ongoing condition. Split billing, okay? We're going to see this a lot. How do we carve out those two services? The answer says, when you're using time, document the time spent in services to treat that medical condition separately, okay? Carve out the time spent performing those services related to that yearly exam. If you're going to base on MDM, choose based on the number and complexity of problems addressed for that ongoing condition, okay? Outside and separate from that physical exam or that yearly exam. If you can cut and paste over here and have an MDM level, great. Or have extra time spent on that issue, great. But we need to have both documented, okay? It should make sense because it's not a lot different. Our question concerns the number and complexity of problems addressed in the MDM table. This is the bigger, wider column in your MDM table that has the purple heading across the top. How would we categorize a personal history of cancer? What do we do with that? The answer says base the decision on the reason for the encounter today. Is your patient having symptoms? Determine how those symptoms fall into the bullet points there in the middle column there of that MDM. Is the patient still within medical protocols to be having the disease or active with the disease? It could be a chronic stable illness. Okay, you have to make that decision. Our question concerns the number and complexity of problems, again, in that middle column of the MDM table. How do we count a family history of diabetes or cancer? Base the decision on why the patient's there today, what you did. The patient has a family history of a disease, but maybe doesn't even have any signs or symptoms. We're going to look at medical necessity, okay? I'm going to look at medical necessity. Medicare is going to look at medical necessity. Okay, Medicare does make payment for some preventative services, but the provider needs to look at the procedure code that most accurately reflects that service. Next question. My physician ordered a complete blood count, chemistry panel, and lipid test for the patient today. Those three things. Can I count this as 3 unique tests under the new amount and complexity of data? Again, that middle column. That MDM table indicates each unique test. Those terms are right there in that chart. Therefore, you could count each order separately to meet the requirements of Category 1 tests and documents. Low level of MDM would require 2. Moderate and high levels would require 3. The definition of tests is each unique procedure code that's ordered. A CBC has a different lab CPT code, okay? It starts with an 8. A chemistry panel has a very different and unique lab CPT code, okay? Same for the lipid test. We ordered multiple labs or x-rays. Must the diagnosis be different for each of these tests to be counted as unique? I want to say the diagnosis doesn't matter when we're counting up all the things that you've done and we're giving you kind of a bullet point check mark list in that middle column. The diagnosis for each test must reflect why the practitioner is ordering the test. It gives medical necessity, right? But they don't have to be different. Okay? A patient is a child and the parent provides the history. Do we meet the independent historian requirement, which is in the middle of that MDM column as well? Yes, definitely. It's part of the definition of an independent historian. You can give yourself credit for that if you have to talk to the parent through the child. The office staff uploaded test results ordered by an outside source into our patient's medical record. Can we count this as review of results of each unique test? As part of the amount and complexity of data to be reviewed, that middle bigger column again in your MDM table, Medicare requires documentation of the review of the test results. Medicare requires you to note that in the note. If there's no documentation, you can't use it to choose your level of service. You can't give yourself credit for it unless it's noted in that note. Remember, if it's not documented, it's not done. Medicare would look to see documentation of the review, not just a practitioner's signature on the total note. You have to show that you reviewed it and this is what you found. As an ophthalmology office, there are several tests that we perform as part of our E&M service. They don't have procedure codes. Can we count these tests in that middle column? It says do not count as an amount and complexity of data if there is no unique procedure code. It would just be part of your main E&M service. Okay, that might help some of us. Our physician ordered 2 tests with the same procedure code. For instance, a right and left elbow x-ray, maybe a comparison view. Would we count this as 1 unique test or would it be 2? Medicare is saying it would count as 2. Even though your procedure code is the same, your CPT code is the same, it really is 2 unique tests for that patient, 1 view on the right and 1 view on the left. What documentation does Medicare need to count a review of a test? And we talked about this a little bit up above. A notation showing the physician reviewed the findings and the result of his or her review. You have to prove it. Okay? You're the only one that was there with the patient. You have to tell the story of what happened in there. It has to be in your note. If it is, you get credit for reviewing. Okay? You can get a credit and a bullet point for ordering a test, and then you get a bullet point for reviewing the test. Okay? A question was asked of me the other day, and it's a great question. If I order the test today and the results come back next week, and then I have a visit and I talk about those results with the patient, you can get a credit for ordering it today, but you get the credit for reviewing in 2 weeks when the patient comes back. Okay? Please explain further prescription drug management. This is a really good one. You'll note prescription drug management is on the moderate level in your MDM table over on the risk column, all the way over on the right. But what does that mean? CMS is saying, and WPS is saying, prescription drug management is part of the moderate risk category. These drugs require a prescription. If you have an over-the-counter drug that's ordered at a higher dosage, it's not considered a prescription. It doesn't require a new drug, a new dose, or a discontinuation of a new prescription or of a current prescription. The medical record will show the physician work to determine the medical necessity of those drugs. An encounter documented as only a prescription refill without any documentation of an E&M service is not going to suffice here. Okay? You have to show the expertise, the thought process, and what you did for that medication. Okay? How will Medicare determine minor or major surgery? I talked about this a little bit with Dr. Remington the other day, and we talked about how it says they're going to identify based on the physician fee schedule of 0, 10, or 90 global days. But this is kind of a kicker. We would also review any medical record data that's specific to the patient, so that might be helpful. Are all payers going to change to the new guidelines? We don't know. We're going to follow it as Medicare says we should. The last 2 questions are really good. I'm going to get cut off here pretty soon. 99358 is a code that more and more providers have started to use. We can't connect it with an E&M visit anymore. I want you to read the screen on that. And what do we do with telehealth? Telehealth doesn't matter. It's all going to get paid the same. You don't have to do anything different with telehealth. I hope these questions